This week on the BackTable podcast.
Depending on what size practice you're in, right? So if you're in an IR practice and there's 20 of you and you want to build a PAE program, I would say, well, 2 or 3 of you should become the initial point people / faces of that and to build. Because then over that first year, let's say maybe you're lucky enough to get 30 cases that first year, and there's 1 or 2 primary operators. Maybe somebody's even able to scrub in to assist, but you have a couple people that are really learning from that. Whereas if you have, again, 20 people and everyone does 1 or 2 over a year, you're really not developing expertise. So I think trying to work that out in your practice is important.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or backtable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community. First, a brief word from our sponsors.
For over 35 years, Merit Medical has been creating confidence-inspiring tools for the IR community. In addition to the market-leading Embosphere microspheres, Merit has developed a full portfolio of embolization agents and delivery systems, including the first commercially available steerable microcatheter, SwiftNinja. Designed for speed, control, and precision, the SwiftNinja steerable microcatheter allows for rapid selection through tortuous and difficult anatomy, with or without the use of a guide wire, thanks to a fully articulating tip that deflects up to 180 degrees in opposing directions with the turn of a dial. The SwiftNinja also features a tungsten braided shaft to enhance support and pushability, and 3 radiopaque marker bands to aid in precise navigation during your most challenging PAE, liver, and other embolization procedures. Learn how the SwiftNinja can bring speed, control, and precision into your embolization practice by visiting merit.com/SwiftNinja. Now, back to the episode.
This is Michael Barraza returning as your host. I'm joined today by Dr. Jason Hoffman at NYU Grossman Long Island School of Medicine. We are going to be talking about what's new in prostatic artery embolization, or PAE. How's it going, Jason?
I'm doing great. How are you? Thanks for having me.
I'm good. So are you in New York City?
I'm on Long Island. So the hospital that I work at has merged into the NYU system a number of years ago. So I'm based, we have a Long Island campus that I work at, but we're sort of part of one large department through NYU.
Right on. A lot of our listeners are trainees. Could you tell us a little bit about your department and the program?
Absolutely. So within sort of NYU as a whole, there really are a couple of different campuses. The department that I work at, again, is on Long Island at a hospital formerly known as Winthrop Hospital in Mineola, New York. It's about 20 miles east of Manhattan. Just based on the lovely suburban traffic or traffic that we get in a lot of parts of the country, it's really not functional or appropriate for us to sort of have one big functional group. So while we are one department, we have a sort of a Long Island practice and also a Manhattan-based practice. So at the campus that I'm at, we have actually our own medical school now. It's about 5 years old, and it's a primary care focused medical school, but we do support the education of trainees, people that happen to choose radiology, and then those that go into primary care. Through the department as a whole, we have historically 2 residency programs. Over time, the Long Island-based residency is sort of sunsetting, merging into a larger Manhattan-based program. But we certainly, on our campus, educate trainees. Currently still have some radiology residents at an ESIR program. So, I have a trainee going into IR this year who'll be graduating and is doing his final ESIR year with us. The hospital, the main campus I'm at, is a level 1 trauma center, a busy oncology center, stroke center. So we do sort of the gamut, run the mix of all different IR procedures, both larger and smaller, shall we say. And I've been there for about 14 years at this point, so lived through a merger and then all that goes with it, and have been doing prostate there for, I'd say, about 8 years at this point. So I've done many hundreds of them over time and worked pretty hard to build the practice, and some younger or newer faculty that have joined in the last couple of years, get them up and going. So it's been a pretty cool experience over the last 7 or 8 years.
Yeah, that's awesome. So, we're going to talk about what's new in PAE, and, this is something obviously that has evolved fairly rapidly over the last decade. One thing that stands out, of course, is the new AUA guidelines. Has that changed anything for you?
It's great that the guidelines have evolved, right? We know that a lot of people, different societies, individual IRs have really worked to sort of be involved in that and really to sort of change that process. And I realized it's still with less than a year ago, right? So the fall of 23, where the AUA guidelines changed, that had followed the EAU, which is the European Association of Urology. Those guidelines included PAE and BPH management a few years early, I think in 21. And then years before that in UK, the guidelines had been updated. So I do think that while it's great, right, the guidelines are evolving and getting updated, it's going to take some time for sort of insurers and then also maybe some urologists to sort of understand and accept, right? So just because the guidelines have been updated doesn't mean that we all can sort of take a sort of a breath easy and just say, okay, well, now we're good, right? I do think it's great. It's great process, great evolution. Hopefully we'll see actual coverage listings online, for example, and then big payers and covers will show that they will now absolutely cover. It's still evolving. In my practice, I'm still having to occasionally do some peer-to-peers and write letters, but most of the time getting approvals. I hope that will get easier / smoother here over the next sort of 6 to 12 months.
I'm with you. I haven't had any noticeable changes since it's happened. I still struggle to get insurance coverage, and I particularly struggle to get buy-in from urologists. Almost all of my PAE patients are self-referred. I get the occasional one from a urologist, where the patient shows up and knows what he wants, but it's really tough for me to get them on board. And so, with that in mind, my next question is like, what is your referral system like? Who all is involved? And, how do you take a patient from, walking in the door to the table?
Sure. If I can just circle back just for a second, even on what you were just mentioning, I think it's a real phenomenon, right? Just because the guidelines haven't updated, it doesn't mean that every urologist or every referrer even knows them or will necessarily embrace PAE to the same degree. So that being said, hopefully as we do more and more and have even more data down the road and we have more IRs practicing and doing great work in this space, hopefully we'll open up more and more eyes beyond the guidelines. That being said, for me, early on when I was building my BPH program / PAE practice, I was fortunate that I did have a number of different urology practices on Long Island that I had a pretty good relationship with, whether it be from some of the bread and butter GU procedures, whether it's nephrostomy and stonework, varicocele embos. I did a reasonable amount of, or still do, of renal cell or renal mass ablation. And not that those were the exact same urologists that eventually now are referring to me, but I do think I had a pretty good rapport and was sort of trusted and respected for the most part, right?
Yeah.
Maybe not everybody loved the work that IR would do, because I realize some people see it as perhaps a competition. That being said, I did have, I think, at least some urologists in the community, both at a few different practices and then also at the institution, that at least, I guess, valued the work of IR for them and for their patients. So that not everybody has that, I realize, but for me, that was nice. That being said, to this day, of course, right, there are some urologists that are really just not going to want to send patients for various reasons. Sometimes it's economic and sometimes it's a certain bias because they might do another procedure that happens to be sort of in competition, shall we say, for that patient. I try hard to reach out to those folks, right, and have conversations. But if somebody doesn't really want to listen or keep an open mind, there's only so much that can be done. I've also been fortunate early on, this is years ago, when I was invited to participate in Urology Journal Club or at a multidisciplinary conference, talk a little bit about PAE. I had a couple of urologists that really sort of stood up and not only embraced it, but really advocated, because they had some patients that we as a team were able to help. And that not only did I help those patients, I think followed them appropriately, good longitudinal clinical care, but I didn't sort of steal the patient, nor did I sort of dump management back on them. And I think for those patients, it happened to, and they came back to their urologist, were so grateful that they were sent to me for consultation. So that actually, our success for that patient actually made the urologist look good. And I think for those people, they said, okay, look, there's a real opportunity here. Now, I would be foolish to think that everybody is sending me all their patients, right? I mean, that's it. That's silly. I mean, clearly there's competition and there's other procedures that also get offered to men with symptomatic BPH. So sure, word of mouth is important, other types of marketing. Lots of my patients now or patients that I'm seeing in clinic are referred by their friends. I remember early on when I was doing some prostate education and teaching, a bunch of years ago, somebody said, oh, it's just like Eufy. I'm like, well, I think I made a joke. Well, the one thing to me that this is like Eufy is that if I treat a patient for fibroids, it's quite common that they will send a family member, a friend, a colleague that also has the same symptoms. So it's not that the procedure is the same. I mean, technically it's quite different, and typically PAE is much more challenging, but many patients at this point have come to me from friends/family members/colleagues that had positive experiences and valued the way that I think we as IRs will evaluate and manage and treat our patients. And that I think is paying dividends for our practice.
Totally. My best referrers are previous patients.
Absolutely. And I know many of us have had, I'm sure you have had this happen too, where patients will say, look, if there's a patient that's on the fence, give them my number, I'll talk to them. Or if you're building video testimonies, let me know, doc, I'll send you a video, or you can record me. And I realize not every patient is going to be that enthusiastic, but there are a lot of men that we fortunately have been able to help, right, in terms of their BPH and their lower urinary tract symptoms. And it can be life-changing for a substantial number of patients, and to sort of harness that positive energy and try to help spread the word and market / make sure people are aware and learning, I think is important.
I think you brought up a really important point about being established before you start taking something like this on. And it's an important mistake that I made early in my career. I'm in my second job, and in my first job, when I was in Nashville and PAE was new, I was really excited about it based on, preliminary data and preliminary experiences that had been published. And so I contacted Ari Isaacson, who was at UNC at the time, and I flew there, watched a couple cases with him, and I came back. I'd been in my job for maybe 3-4 months, and I started calling urologists like, hey man, like, let me start doing this. And like, who the hell are you? And I didn't see a single patient. And so when I started my current job, where I've been for about 4 years, I waited, the marketing people in my practice are like, you should go ahead and give a lecture to the urologist. We'll put you on the radio. And I said, no way. Like, I'm not doing anything. I'm just going to work here for a couple years. And I waited about 2 years before I started pitching it. And I only pitched it. And I was like, look, like, I know what you guys are doing for prostates. Like, just give me the giant glands, give me the ones that are catheter dependent, and let's start with that. And that was a much better step for me, was waiting and getting set up before I pitched that, because then they're like, all right, well, we've seen your work. We know what you do. We can trust you with these patients.
Absolutely. Early on, right? Like hematuria patients, like you said, giant glands, maybe patients who are, just not good sort of candidates. And again, these are patients that the urologist might not have as much to offer or have a harder time managing. And if we're able to provide those patients a good experience and a good clinical outcome in a overwhelming majority of patients, that opens up some eyes, right? And it builds trust, and it maybe to some degree builds some sort of belief in the procedure. But that being said, years ago, I mentioned that part of that relationship I had from my other GU work, I think, helped me. When I first came to this institution, to the hospital, it was called Winthrop at the time, when I tried to build my IO practice, right, and start building my ablation practice, didn't go quite as efficiently, right? It took some time, and I really had to build relationships and sort of prove myself, whether that's fair or not, right? That's the way the world often works. I've had the honor of having some younger colleagues join our practice over the last couple of years, and a couple really eager to get involved in PAE. And one in particular has really sort of helped take the reins and admittedly walked into a practice that was pretty busy, and I was having trouble almost probably doing the number of patients that were referred to me, but also want to not just sort of say, here, do these procedures, right? You have to understand the literature, understand how to work up a patient, understand when to say no, when to enthusiastically say yes, right? And again, and not just how to access a vessel and whether it's a radial artery or common femoral artery, and then how to eventually get into a small prostate artery. There's so many aspects to it beyond the procedure that I think it can be very rewarding when you're really managing these patients. And not everybody has a really smooth experience either, right? No procedure is perfect. So occasionally you have a failure, occasionally you have a patient get a UTI or have a more severe post-embolization syndrome, but really having that comfort and ability to just support your patients and really want them calling you, right? Not a urologist or not somebody else. We want to be managing these patients and sort of taking ownership of our work. And I think, IR in 2024 is great with that. I mean, we always have room to grow, right? Room to improve. Many of us probably still struggle with whether it's practice leaders or instant hospital leaders, or maybe it's a private practice world where, if the DR boss, shall we say, isn't quite understanding the value of clinic. For us, we know it's important. I think we're in a better place now than we were 10 or 20 years ago, but still room to improve.
Absolutely. I don't think I could do these cases without a clinic. Like, there are some cases that could work well in the old school model where they show up for the procedure and that's it. But I think that there's a lot of setup involved with these and a lot of setting expectations. So let's talk about how you work these patients up. The ones that come from the urologist, those ones have already gotten, at least in my experience, they've had ultrasound, they've had uroflow, they've really had all the workup that I need for the most part. And, unless you want to get imaging. But as I said, a lot of mine, the majority of mine are self-referred. And early on, those are ones that I struggled with in terms of workup. What do I need to do? What can I get away with? So how would you, take a patient that's self-referred for BPH and work them up for this procedure? And if you can, touch on the ones that you mentioned where, you know when to say no.
Sure. So when, if a patient's scheduling calls to schedule a visit and is not through a urologist, right, through a self-refer, if, I'll try to ask the scheduling team, look, find out if there's any imaging, right? If there is imaging, I want to review it, whether it's an ultrasound, MR, CT, I want to know what's been done for whatever reason, right? Maybe there was a CT a year ago for another reason that I can at least take a look at and understand right away where we are with size of the gland. Before I see the patient, when they register that day for the visit, they're going to fill out the IPSS and score sheet and do the quality of life score. I think understanding where people are with baseline erectile function is important as well. And then depending on when I sit down and talk with them and I have a sense of what's most bothersome to them, again, look at their IPSS, look at the quality of life score. If there is imaging, I'm going to review it. I certainly want to know the size of the prostate. But if they have moderate to severe lower urinary tract symptoms and they've progressed despite medical management or perhaps couldn't tolerate some of the different meds that get used, I'm going to have a relatively low threshold to really start embarking on deciding whether or not to treat, right? Because if they have an IPSS in sort of in the low teens and above, you really can talk about treating. That's when, to me, the size of the gland becomes important, because when we look at all the different procedures that can be performed, 80 grams-ish is sort of the vertical sort of dotted line where you have one group of procedures that urologists will sometimes talk about, the MISTs, right, the minimally invasive surgical therapies, Resume, UroLift, things like that, maybe TURP. And then as we get bigger than 80, certainly bigger than 100, we start talking certainly less about that, more about prostatectomy, HoLEP, other things like that, aquablation. Now, PAE certainly can be offered across the spectrum, but when we think about the risks of and the tolerability of some of those larger procedures that urologists do for larger glands, PAE starts to really have a nice sort of spotlight shined on it in terms of it's markedly less invasive, right? Lower risk. You could use less medication in terms of anesthesia. In theory, you could do it just under local if you need it, but certainly light to moderate sedation in most cases. Lower risk of erectile dysfunction, ejaculatory dysfunction. We can do our procedure on anticoagulation if needed, right? So it really changes the dialogue for me in terms of what to compare things to, right? I want to make sure that I'm able to talk to my patients about some of the other options that can be done. I don't sort of overstep, right? I know I'm not a urologist, but certainly it's my responsibility to know about these things. You used a phrase before that I use all the time when I'm talking about PAE, whether it's to trainees or other providers or other IRs, setting expectations, right? Making sure the patients understand why we may do this procedure, what the procedure involves, what they'll feel after, what outcomes will be. But also setting expectations in terms of an educational standpoint. So again, I'm not doing UroLift. Obviously, I don't do Resume, but I think it's important for me to know a bit about it so I can talk about pros and cons. And if somebody is really on the fence, I may then, if they don't have a urologist, I might refer them to a urologist that I have a relationship with, so that we can then work together and determine what's best for the patient. But if there's no imaging, look, it's easy to quickly to either be done in the office or send them to a radiology area center to do at least an ultrasound and post-void volume, right? Because post-void residual can be important to know. I think early on in someone's practice, to be able to get a CT or MR can be really helpful to understand the anatomy, to understand sometimes, right, a good quality CTA or even MRA, you might be able to actually go into it, at least pick up if there's a corona mortis, for example, with the prostate artery coming off of obturator. Rare, right, but that happens at times. If you do enough of these cases, you're going to see that. And you might have a sense of the degree of atherosclerotic disease, things like that. For me, whether or not somebody has atherosclerosis isn't necessarily going to change me offering the procedure at this point in my career, but it does, again, help me set expectations for the patient, where if somebody has markedly tortuous atherosclerotic vessels, I might sort of tone down I'll tell them the truth about what my technical success rate and clinical success rate is, but I might say, look, I believe that your procedure is going to be particularly complex, and there might be a slightly higher chance that I can't get into a vessel based on this very extensive disease. But if it's a really large gland, they're symptomatic, they're miserable, and they really want to avoid transurethral instrumentation for whatever reason, typically still going to offer the procedure. But again, I want to set those expectations well.
I sometimes kind of like it when they don't come with imaging, because for me, it's an excuse to get the CTA. Then I can see what I'm working with, because I don't get it on everybody. But if they don't have any imaging, I usually just go straight for that, because I can measure the gland on that, but then kind of get ready for the procedure.
Absolutely. And, again, some people, I think we're past the conversation of the debate of relatively past in terms of radial versus femoral, how to approach. I mean, I typically tell people that I would make the joke that, look, if you typically do one approach, don't do your first prostate approach case as the opposite, right? Use what you're comfortable with. We have great catheters and wires and microcatheters, and again, in 2024, even better than we had 5 years ago. But again, to get a map of the anatomy, a lay of the land, I think can be really helpful. Again, to me, it's less important now than it would have been 6 or 7 years ago. But again, for those that are looking to sort of build their practice, having that information is important. And again, if you have a patient that just looks like it's going to be particularly difficult, and maybe you're in a practice where you have some other partners that you can sort of run things through or share some ideas about, maybe you talk about it, right? Because we certainly want to do the right thing, of course, for each of our patients. And my bias is such, and my experience is such, that usually PAE is a really good option for many patients, but again, particularly like the situations I mentioned, 80 grams and above, again, hematuria, failing medical management, maybe they've had a prior TURP. Again, these patients typically do very well after embolization. In my experience, if they've had prior interventions, and I definitely want to know about that, you start to sometimes see more bizarre vasculature. So if they've had a prior TURP or even a prior Resume or Urolift, sometimes you find more bizarre vasculature. And it just, for me, again, setting that expectation for the patient to let them know that, yeah, absolutely, we can still do it, but you might have a couple other vessels that I have to embolize as we're working. We don't want to leave any flow to the gland visibly, right, that we can see. So in a perfect world, everybody has 2 prostate arteries, 1 on each side, and it's a real easy access. But as you know, some of them can be real difficult to access. Sometimes you have multiple collaterals, and trying to navigate that and understand how to treat to maximize getting really good stasis, right, in the vasculature is important. I think 5 years from now, or maybe even 2 years from now, we'll have more and more information about what's really the best technique, right? Should we be using a certain particle? Should we be using a certain size range? Where are we going to be down the road with liquid embolics, coiling out, all these different things that some people do. Early on in practice, I typically encourage people to try to do where the most data is. And for me, that's particles. That may evolve over time. I totally understand the concepts about minimizing recurrence rates. And if you're coiling out, or if you're using liquid embolics in a particular way, perhaps down the road, if there's data to say, look, these patients do better. We also have to probably talk about cost effectiveness at times, but from a pure clinical outcomes perspective, we don't have really long-term data on that stuff yet, but we'll see. And that's part of what's exciting about this, because I think we'd all would be probably naive to think that in, 2029 or 2034 that we'll be doing things exactly like we are now. That's part of what many of us love about IR, is our innovation and developing and using technologies in different ways, or embracing in a careful, evidence-based way new technologies, right, as they evolve and come out.
So let's talk about how you're doing them now. Are you doing both radial and femoral?
I'm sort of a femoralist, shall we say, and there's a sort of a funny story behind it. So I'm typically going femoral, and basic sort of 5 French, 10 centimeter sheath. I'll get up and over the bifurcation with a 4 French and a sauce type catheter, and Omni just to get up and over. I usually use a uterine type catheter to select both internal iliac arteries. Typically, I'll get into that sort of main internal iliac, if that makes sense, before the bifurcation to anterior and posterior. You get a good angio, right? Typically, we talk about that 30-degree ipsilateral oblique, maybe a steeper oblique at times. Map out the anatomy, make sure that hopefully I can tell every vessel that's going in the gland. And if I'm not sure, I need to study these different vessels. I'm a big fan of a steerable microcatheter. It's called SwiftNinja. I know that's somewhat controversial. It's a little more expensive than I appreciate microcatheter, but I actually did some studies on it early on and found that it was saving me a lot of procedure time and contrast and radiation exposure, and that it's like extraordinarily unlikely for me to not get into a vessel with it. I often don't even need a wire. Usually can get right in. So that's just me. That's what I'm typically doing. I'll get into the prostate artery and at a minimum do AP and 30-degree oblique angios after I've given some nitro. Early on, I was doing a lot more cone beam CT, I don't do it 100% of the time now. I consider it more of a tool at this point for me. But I think, again, early on, I think that's really, really important. Make sure that we're finding vasculature to the entire gland, and make sure that we're covering things, and make sure that we're minimizing risk for non-target embolization, of course. When I do my embolization, I'm typically doing 300 to 500 micron particles, typically embospheres. If there wasn't a non-target embo risk, then perhaps using smaller particles is what I would do always, because I know there's some data to suggest a little bit better ischemia. But I do worry about symptomatic non-target embo, and smaller particle size makes me a little bit worried with that. If I'm treating a smaller gland, less than 80, I sometimes use some 1 to 3s and then go up to 3 to 5s. But most cases I'm using 3 to 5s. I go quite slow when I put those particles in. I want to get to stasis, of course, really get a good embolization. I'll do intermittent angios just to make sure no intraprostatic collaterals are opening up. I've definitely seen that happen, and it's been pretty eye-opening a few times to see pretty giant intraprostatic collaterals open up that, I bet my house on the fact that really was not there initially.
It's scary.
So it's something to be aware of. It is. It's. I had a few that I'd scratched my head and said, how did I not see that before? And I went back and I showed a few people, can you see anything? And no, they just weren't there. Flow dynamic, we know this in liver treatments and all sorts of things, right? You can get all sorts of different flow dynamic changes that happen. So once I'm basically to stasis, if I have a long prostate artery, I sometimes will put some gel foam right at the ostia. Not gel foaming the whole thing, but to me, that gives me a little comfort. I wish I track my data with that better, because I've done it many hundreds of times over the years. And I feel like, I know that my patients in terms of statistics are doing as well as typically we're seeing a report in the literature, if not maybe a little bit better. Again, I wouldn't gel foam the entire vasculature, right? That's right at the end after I've been really happy with my embolization with the particles.
I do the same thing. I do it with a slurry. Do you do a slurry or a pledge it?
I do it with a slurry. And I realize that that's hard to define, because you could make slurries all different sort of consistencies, I realize. So, one has to be comfortable with mixing it, the slurry thickness, right, that you want. But that's typically what I do, although I know some people will shoot a little pledge it out there just to try to get it right at the ostia.
Let's go back to the study you mentioned on SwiftNinja. So you guys looked at cost, radiation exposure, and what else did you say?
Yeah, so this is a number of years ago, but so truthfully, when I first heard about it, I said, oh, I don't need it, right? I mean, I can get wherever I need to go with most catheters, wires, things like that. The first time I used it was a liver case, and I was doing a mapping, and I was looking at all different vessels, and just for the life of me, every once in a while you get a left hepatic artery that just has like a real crazy angle coming off the proper hepatic, and I was trying a bunch of different wires and couldn't get in, and one of the techs was like, you should try the new cerebral microcatheter. I'm like, I think I'll be okay. And I poked around a little while longer. I'm like, you know what, let's open it up. And I kid you not, seconds. I mean, like 3 seconds. I get a sense of the shape, how to curve it, and I'm in. I said, okay, well, maybe there's something here, but it's an N over 1. And then I, a few other times, used it in difficult cases. I tried to eventually get to the point where, I don't want to use a lot of extra equipment, right? But if based on the initial angio, right? So I don't know, in a mapping or something, if you see wherever you need to get to, look at that initial 5 French catheter angio, whether it's in the celiac artery or an SMA for a GI bleed or internal iliac for a prostate. And if it just looks like real difficult vasculature, I started then going directly to it, and then found consistently that I felt like I was being more efficient. Did a little study, this is a number of years ago now, used like sort of complex angio/embo cases. So, not a low bar Y90, right? But a super, super selective, distal branch embolization, whether it was an interventional oncology case, a GI bleed, prostates. And then I was tracking timing it took to select vessels, time of radiation exposure overall, contrast use overall, again, procedure efficiency. And I found all this stuff was statistically significant in favor of when I was using cerebral microcatheter. And then in that paper, I think it was 65, maybe 70% of the time, I forget exactly, I also was not using a wire. So while the microcatheter did cost more, I was using less equipment overall. I was, any of us could ask, whether we're in an OBL or whether we're in a hospital or anywhere in between, somebody up above us could tell us what it costs per minute, literally, to run our rooms. So Absolutely. I was able to get some of that data. This is years ago, so I realized the numbers are evolved. But when I calculated the amount of time saved for procedures, it was incredible in terms of what an institution, and this was Winthrop Hospital at the time, would have sort of determined that value to be. So again, for me, it's a great device. I really like it. We get it in, I think anybody can, you get it in bulk, so you pay less for it,
Right.
per price, whatever. And I think the shelf life is pretty long. So it's not like you have to use it in a week or something. I think it's
Right.
many, many months, if not longer. So for me, for like complex angios and embos, it's probably my really main go-to, although there's, other things that I'll use. In prostates that are, more straightforward, look, I don't think you always need it, but my other go-to would be a swan-shaped microcatheter, and typically 2.1, 2 French. The SwiftNinja is 2.4 French. It's a little bit bigger, but that's a fraction of a millimeter, obviously, 0.3 French. And the trackability, it's pretty amazing. I've gotten it to places in the body that like scratch my head in terms of where I could get it to go. Now, very long answer, but that's part of the reason I still go femoral, because when that device was still first introduced, it was 125 centimeter length. So there was no real radial option back then.
Right.
That's different. There is a radial version of it now, but I guess I'm so comfortable and been done so many femoral that, I haven't really switched.
The base catheter you use after getting up and over, use a uterine, but it's like a ruck.
So, there was a period of time in the past where the ruck was off the market due to some, coding issues that they had, and Merit had one that had been sort of redesigned a little bit. So I think they call it the modified uterine catheter. But yeah, so Cook-Wake makes one, Merit makes one. I'm sure other companies probably do as well. But that's the type of catheter that I'll typically use. If I can't get that to form, then to get up and over, sometimes I'll use a Cobra. In a real difficult case, tortuosity, atherosclerosis, I might put a longer sheath up and over, of course, for stability. And for whatever reason, if I can't use the uterine type preformed catheter on the ipsilateral side, then I might use a Matajame or some sort of reverse curve catheter, Simmons, things like that, to hook into the right side, the ipsilateral internal iliac, and do my run there.
Right on. So you treated both sides and, you get hemostasis. They're going home the same day?
I'd be lying to say that nobody's ever stayed overnight, but I think the two that I've kept over the years were planned that somebody, sometimes you get a patient who just has maybe high comorbidities and really no infrastructure, social support, and you're just like, it's safer to keep this person for a night just to keep an eye on them. But that's less than 1% of patients. So yeah, they go home the same day. I keep them on bed rest for a couple of hours after the procedure. I typically use a closure device. I will have ordered meds to their pharmacy either before the procedure, or at least that morning. Either myself or one of our NPs will send meds to the pharmacy. And again, you said, you talked earlier about patient expectation. I think that's really important because we're used to dealing with post-embolization syndrome, right, in a lot of different embolizations that we do. But it's, a little different, right, for PAE. So I often will joke in the office with patients that they're not going to love me on day 1 or day 2
No.
due to dysuria, urinary frequency. But usually when I see them at the 4 to 6 week mark, I'm getting a high five, a hug, a letter, whatever. It's amazing how many patients have written letters to like various leaders on the institution, and more so with PAE than tumors we've ablated and /cured. It's amazing how life-changing this can be. But setting those expectations are really important. And I go through the meds that I can get there in a second with you, with the meds that I use. And I promise every patient that I'm going to call them the day after the procedure, which is true. Our NPs are awesome. Our nurses are awesome. But the patients know me, right? I spent a lot of time with them in the initial consult. So I call every one of them. I don't care what day of the week it is. If I'm on call on Saturday or not, if I do a case Friday, they're going to hear from me Saturday. And that sort of what is real accessibility, but also just the perception of that. And they know how to call us, right? If there's questions at night, it's rare to get a question at night or off hours. But again, we want patients to call us, not call their PMD or not call their urologist, because we're the experts, right? We should be managing these things. So I talk to them about hydration. I talk to them about, Motrin. I typically use antibiotics for about 7 days after the procedure. I usually use Pyridium, right? That helps to decrease burn and irritation, dysuria. I joke, I'll tell them in the office, I'll tell them the day of the procedure about the urine changing a funny color, right? Reddish, orangish color. And still a substantial percentage of them, when I call them the next day, are like, Doc, what happened? My urine's a funny color. Well, it's okay, sir. So what I was referring to, it's hard. We're telling them so many things and nobody's going to remember 100% of what we say, right? So sometimes that repetition, spending 2 minutes or 3 minutes, even if it's 5 minutes on the phone the next day with them, they value that tremendously. And I think that has actually helped me build my practice, right? I didn't realize that maybe at the time, but I think that they have these positive experiences, whether they're telling their urologist, they're telling their friends, they're telling their PMD. It really does help as an accidental sort of word of mouth marketing. When I check on them the day after the procedure, again, I'll use Tylenol if they need to as well. If they're having spasm issues, I might use Vesicare or oxybutynin. But usually those first few days, right, they're not so fun. They're urinating very frequently. Again, I'll usually point to their IPSS form and say, look, here's where you are. It's going to get a little worse before it gets better. But with these medications, we should be able to keep it tolerable. Rare to have a Foley and go into retention, but we talk about, I can mention that after, but the group of people that I think are higher risk for that. Again, trying to set expectations. I try to get them usually to drink a little bit of extra fluids for the first couple of days, an extra 2 to 3 glasses of water a day. Be a little careful, of course, with what their comorbidities are, but we'll want to get them through that. And our nurses in the procedure area typically call the patient 2 or 3 days later to check in also. So we have this sort of built-in call it day 1, call it day 3. Again, it's very easy to reach any of the IR docs who's on call as needed, reach me if needed, NPs. So I think the patients do feel supported, by that.
I completely agree. This is something that I have been and am still trying to build. And so these patients I'll get my cell for better or worse. And, the younger ones tend to just want to text and tell me how they're doing. But, the next day phone call every time.
For many years, I gave my number to everybody. I don't necessarily do that anymore, but I have a low threshold to doing that, particularly if it's a Friday and I'm calling them on Saturday. But I'm often calling them from my cell anyway. I'm not intentionally trying to block the number if they don't have it. Because I think it's important. But you're right. I mean, some people will text pictures and various things, and sometimes you'll get in awkward situations like that. That can happen. But to me, like if somebody reaches out, usually in a way, it's a compliment in a way, right? They felt comfortable reaching
Absolutely.
out. They understand that you are there not to just, again, put particles in the prostate or embolize the prostate. You're trying to take care of them as a person. You're an expert in this. You're an expert in, again, the workup, the actual procedure, the post-procedure management, and part of that is accessibility. And I think most of the time as a specialty, we're probably more accessible than many of their other doctors, and that wows our patients regularly.
The feedback that a lot of these patients have given to me and to their urologists is they've just been so impressed with availability and accessibility, as you said. And I got to say that as much as the outcomes has been what's gotten patients in the door for me.
Yeah, absolutely. Absolutely. And again, I know that with insurance, right, sometimes that politics is local, right? Some people in certain parts of the country, even in the same state, might have different problems with different insurers. And same with me, like with my relationship with my urologist, some of them are really awesome. I think overall, I'm really fortunate in terms of how that's evolved. Again, took a lot of hard work back in my ablation days to build those relationships for PAE, but not everybody has that, right? And, I know before we started the episode, you and I were reminiscing about both of our connections to Penn. And I remember that when I left UPenn, I stayed there as an attending when I finished fellowship briefly, and I moved back to New York, moved home to Long Island. And I was talking to Michael Solon about practice building, and he came and gave a grand rounds at one point early on for interventional oncology, and I think that helped me build some relationships. But he made a sort of a joke to me, was serious, saying, look, it's going to take time, right? You're good at what you do, you're well trained. He's like, but if I came, and he at the time had decades of experience, right, sort of a world famous interventional radiologist, but if he just comes somewhere and hangs up a shield or shingle, so to speak, it doesn't mean his clinic's going to be full the next week. Or maybe even not even the next year, right? It takes time. So, but figuring out what some of those local politics are, who may be in your corner, who may not be, right? It's frustrating. There are some people who just aren't going to play nice in the sandbox and will actively try to hurt you. You won't know it, right? That might happen. I hope not. You hate to hear those stories, but they happen. But that's why you said earlier on, look, jumping right into this can be tricky. If you're at a program where there's a robust BPH practice and PAE practice and you get hired into it, okay, great, but just be aware that that's a different experience than most people will have, early on, and taking time getting settled in, whether it's for PAE, IO, portal hypertension, all sorts of things. Like, just be careful, right? Because you want to try to get comfortable, get a lay of the land, start building some relationships. So that way, when you do have a tough case, a complication, that you have not just confidence in yourself and your team, but people around you really understand that you're great at what you do most of the time, right? I mean, complications don't equate to somebody doing something wrong. It's just, we find ourselves in tough clinical circumstances sometimes, and despite our best efforts and doing things by the book the right way, sometimes patients still have a rough course. And managing that as time has gone on has become easier for me, just with sort of years of service, years of practice. Things that don't make me nervous might have made me nervous 10 years ago, right? Because I have more expertise and insight, and that's just natural, right, as we evolve.
So, I mean, with the experience and the developing this BPH practice, and you've obviously been doing this for a while. You've got to see this go, from the ground up. Do you have any tips for people to, how to streamline their PAE practice using, the right tools and workflows?
It's hard because, again, the politics really can be local, right? So that what's worked for me might not work for everyone. But when I think about sort of practice development and reflecting, I think about a bunch of things. Years ago, when I guess before COVID, travel around doing more talks on BPH, I used to use a phrase like, start small, but with big prostates, right? Try to sort of figure out,
yes,
how to get the right patients, the right glands, right? Because there are certain patients that you're not going to be seen as much of a threat, and you can actually seen as an asset if you're talking about potential competition with urologists, right? If you're at an institution where you're sort of going back and forth. Targeting the audience is important. So you might have certain relationships with urologists or emergency department docs who are seeing patients in retention, placing Foley, sending them home. Maybe you can, get some information out to them. I'm in a unique spot too, where I have a really good relationship with radiation oncology team and urology team. And there's a subset of men who have prostate cancer, maybe low-grade cancer, who are going to undergo stereotactic radiation therapy, who also have a large gland, and they're symptomatic. So I'm not doing anything outside of BPH criteria, but I might be able to embolize, get their LUTs better before they get radiated, and also shrink the gland to make radiation a bit safer. That's being studied more. I think we'll have more data about that over time. There's a whole nother concept to say, well, what if you can just shrink the gland to get it smaller to make radiation safer, even if they don't have LUTs? Well, that's going outside treatment algorithms, at least what's approved for sort of real BPH management currently. But I think that, that as it's being studied, I think there might be a real role there, right? Because some patients that have prostate cancer will be offered Lupron for an actual oncologic benefit, and some that are undergoing radiation therapy will be offered Lupron more to sort of help with gland shrinkage. But that's basically medical castration, which is not what most guys really want to be thinking about. So that Lupron, from my understanding, typically brings the gland size down 30 to 40% in about 3 or 4 months. Well, gee, what can I do that will do almost the same thing in the same time frame, right? So again, right now, I think from a reimbursement perspective, from a data perspective, I don't think the data is there just to go out and do that mainstream to shrink glands. But if those patients also have symptomatic BPH, you could almost kill two birds with one stone in a way, and embolize them for their BPH, shrink the gland to make, again, radiation therapy safer. So all these things, purely in the BPH world, will be exciting down the road. But again, for years, I've been treating some patients to help get them through their SBRT, but I'm not really treating their cancer. I'm really treating their BPH because they're symptomatic, right. But there's a secondary benefit. It's been awesome. Depending on what size practice you're in, right? So if you're in an IR practice and there's 20 of you and you want to build a PAE program, I would say, well, 2 or 3 of you should become the initial point people / faces of that, and to build. Because then over that first year, let's say maybe you're lucky enough to get 30 cases that first year, and there's 1 or 2 primary operators. Maybe somebody's even able to scrub in to assist, but you have a couple people that are really learning from that. Whereas if you have, again, 20 people and everyone does 1 or 2 over a year, you're really not developing expertise. So I think trying to work that out in your practice is important. We all talk about, journal clubs, case presentations, letters to referrers. Sometimes that stuff helps, sometimes it doesn't. But again, knowing your audience, knowing the landscape of where you are is important. When we're on years ago applying for residencies, or I guess we're both, I think, young enough or old enough rather now that we did this sort of the conventional fellowship, right? Where you have the elevator speech, you want fellowship interviews. Well, have a little bit of a PAE elevator speech or elevator pitch or talk that if you are talking with a colleague, whether it's a urologist or someone else, that you can highlight sort of what the value of PAE might be sort of for them. Not that you have to wait for them to send you patients, but at least you can sort of be prepared to talk about that. Again, communication is really important. Again, sometimes you have an opportunity to do grand rounds, do multidisciplinary conference presentations, again, letters, things like that. And sometimes you can go out on the outside, right? Social media, some advertising that way. You might go to various places who will say, well, where do my BPH patients congregate, shall we say? Where might I find a group of men that I can educate directly? And sometimes it's religious organizations. It could be a library in the local town. It could be senior centers, right? There's all sorts of potential opportunities that one could explore. The asterisk to that is that don't bite off more than you can chew, right? So if you're early on in your practice, then all of a sudden the floodgates open and you're getting a lot of self-referred patients, but you don't genuinely have the expertise to work these patients up, then you might be doing a disservice to your patients and certainly to yourself. So figure that out, right, internally, again, for your practice, how you can sort of do that, right? How do you get that workflow going? Again, plenty of awesome articles one could read, right? Webinars one can log into, going to national meetings and going to the PAE or BPH management lectures there. I mean, there's so many things that we can do to educate ourselves, probably more now than ever before, especially with the internet, so to speak. But just being really honest with what your levels of comfort are is, I think, really important.
I'm with you. Jason, this has been great. That's about all I've got. Is there anything else that I didn't cover that you want to review?
No, I mean, again, thanks for having me. It's a pleasure being your guest today. I just, again, would encourage people to, if you're interested in PAE and BPH management and you're relatively green in that world, there's so many resources out there. So explore and do some of the things that I had talked about. We need more people doing BPH management in IR. There's no doubt. I mean, I have a bias, I realize, but I think the future is bright. And if we get more people trained and offer great services and longitudinal care to more patients, we'll be even doing more of this procedure.
I agree.
We're both a little biased, I realize, but all good. But I think it's an important message, particularly for people early out.
These actually, when it goes as planned, these are some of the happiest patients that I treat. The ones that get the good outcome. These are fun patients to treat. They're great to see and follow up.
I'll tell you one quick story if I can. This last minute, I'll be quick.
Yeah.
But I was flying somewhere. I forget where. I was giving a talk on PAE. And I think I'm in the air and I get a text from a urologist being like, oh, somebody they knew very close with, they're flying them up from Florida to New York because they want me to do the embolization. Huge compliment to me. Great. Except that I'm not there, right? But I flew back a day or two later. I do the procedure. He was in retention and clot retention and gross hematuria. And he certainly could have been treated in Florida. There's great people down there. But he wanted to be back to New York and he had the resources to air flight himself up there. And I did the procedure, but a couple months later, the note that he wrote to the CEO of the hospital was just awesome. And he happened to then, not everybody can afford to make a big donation, but he made a big donation. And again, he had the resources, I realized, to do things that the average patient can't do, but he still shared his gratitude in a way. And again, many of our patients that certainly don't have the financial resources to share that life-changing gratitude will, again, write notes. They'll tell you in the office, right? They're hugging you. They're giving you high fives. They're sending you their friends, right? They're sending you their relatives to treat. And again, there's no bigger compliment, kudos to us than that. So I think just what would keep all those listening, and especially the younger IRs out there, just to think about that and hopefully apply that.
All right. Thank you, Jason. Enjoy the rest of your weekend.
Take care. Bye.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.